Hello, dear students. We will resume our discussion on to medical virology, and we will discuss today a very important group of viruses, which is known as paramyxoviruses. You may have heard the term the orthomyxoviruses and paramyxoviruses. The myxo refers to the fact that these viruses, they interact with the mucins, which is a glycoprotein on the surface of the cell. Now, both paramyxo and orthomyxoviruses, they are RNA they are enveloped viruses. And the classical example in case of orthoviruses that we have seen is the influenza A, B, and C viruses, whereas in the paramyxoviruses, we have a group of 4 important viruses. The 4 important human pathogenic viruses in case of paramyxoviruses includes the measles, the mumps, the RSV, which stands for the respiratory syncytial virus, and the parainfluenza virus. So the influenza virus A, B, and C, they belong to orthomyxovirus group, whereas the parainfluenza, along with that of the respiratory syncytial virus, the measles and mumps virus, they belong to a group of viruses known as the paramyxoviruses. Now, compared to that of the orthomyxoviruses, the paramyxoviruses, they are non-segmented, whereas the orthomyxoviruses, they were segmented. They have the helical symmetry, what we call as the helical nucleocapsid. The outer membrane of what we call as the lipoprotein in nature envelope, and the viruses, their negative polarity, single standard RNA genome. Now, if you look in case of orthomyxoviruses, that signifies the influenza virus, they were segmented. They had 8 segments, whereas in case of the paramyxoviruses, all of these, the measles, the mumps, the RSV, and parainfluenza, they have just one piece of the genome. They have the standard, both of these have the envelope. The orthomyxoviruses are comparatively smaller compared to that of the paramyxoviruses. The surface spikes, in case of orthomyxoviruses, as you know, they have hemagglutinin and neuraminidase on different spikes, which are, in this case, we can see that the neuraminidase and neuraminidase receptors, they are on the same spikes. So this is the major difference. Now, because the RNA is negative polarity in case of paramyxoviruses, so these viruses, they are equipped with the RNA-dependent RNA polymerase. And this RNA-dependent RNA polymerase transcribes the negative polarity genome into the mRNA. And because they have the negative polarity RNA, so directly this RNA is not infectious. So the negative polarity RNA first has to be changed into the mRNA, and then it will be transcribed into the proteins. Now, the envelope, which are present on the surface of the spikes present on the surface of this envelope, they have 3 types of proteins: the hemagglutinin protein, the neuraminidase, and the fusion protein. The fusion proteins has the ability to fuse the cells, and this fusion, it makes the cells bigger in size. And sometimes these fusion proteins, they are also hemolytic in nature. So this fusion protein make the cells to become larger in color, larger in size. So all the 4 viruses of paramyxovirus group, the measles, the mumps, the RSV, and parainfluenza, they make fusion proteins. The measles and mumps, their fusion proteins are also hemolytic in nature. And in mumps and parainfluenza, the neuraminidase, hemagglutinin, and fusion proteins, they are located on the same spikes. So these are the few differences that we can appreciate between the parainfluenza and the orthomyxoviruses and the paramyxoviruses, comprising of measles, mumps, respiratory syncytial viruses, and parainfluenza. We'll deal all of these viruses, but first we'll take the measles virus. The measles virus causes disease which we know as measles disease. It is highly contagious viral disease which is characterized by the maculopapular rash, and this is primarily found in case of children. Now, the papular is a blend of a term, sorry. The macular papillary is a blend of a term which is used by the two words, the macule and the papule. The macule, they are the flat, discolored skin lesions, whereas the papules, they are the small raised bumps. So the macropapules, they are made of both the flat and the raised skin lesions that we see in case of measles viruses. Now the important properties of the virus is typically of a paramyxo virus. Now almost all of these four viruses, the measles, the mumps, respiratory syncytial viruses, and parainfluenza viruses, they have almost the same important properties in their structures. All are of typical in nature. The two types of pneumonic spikes are found in case of measles. We have one is the having with the hemagglutinin activity, and other have the cell fusion and hemolytic activity. So the spike of measles virus, they have two different spikes. One is with the hemagglutinin activity, and the other is one with the cell fusion or hemolytic activity. Now there is a single serotype. This means that the immunity against one virus will provide immunity against the other also. And the neutralizing antibodies that are paired or directed in the body, they are paired as the hemagglutinin antigens. So neutralizing antibodies, they are directed against the hemagglutinin antigen which is present on the spike of the measles viruses. The natural host for these measles viruses, they are the humans. Now, if you look at the replicative cycle, I will take a few minutes on the replicative cycle of the measles viruses, and the rest of the viruses like MUMPS, the RSV, and parainfluenza, they almost have the same replicative cycle. So we'll not discuss that in the rest of the three viruses. So let's take a few minutes. In case of replication of virus in the body, the virus is brought to the cell surface via the hemagglutinin receptors. It then penetrates and it uncoats. After attachment, penetration, and the uncoat of the virus, the viral RNA polymerase, it transcribes the negative standard genomic mRNA into the multiple copies which are synthesized as a result of this. We know that the virus is negatively standard RNA. So the RNA-dependent polymerase will transcribe the negative standard genome into mRNA, and it will synthesize its many copies of the mRNA, and each copy will translate it into a specific viral protein. So all those viruses, which are negative standard RNA viruses, they carry their own RNA-dependent RNA polymerase, which really transform them into the mRNA, and the multiple copies are formed, are synthesized, and each mRNA has the ability to synthesize into or translated into a specific viral protein. The virus needs two types of proteins, the structural proteins and the functional proteins. Because of the small genome of the virus has the capacity to build all of these genes for the synthesis of the structural proteins as well as the functional protein. The helical nucleocapsid, it is assembled, the matrix proteins are mediated into the interaction with the envelope, and the virus is released by budding from the cell membrane. So this is how the virus replicates. It is absorbed through its receptors, penetrate, uncoat, changes negative standard genome into the positive standard mRNAs, synthesize different molecules, and make its proteins. And then these proteins, they synthesize the virus structural proteins and the virus functional enzymes. Now, the transmission of this virus is through the respiratory droplets, which are produced by the coughing and sneezing, and the disease is worldwide in distribution. The outbreaks of the measles virus has been reported to occur every 2 to 3 years, but they are confined to the specific areas. So they are the sporadic outbreaks, and there is not really a big population which is being involved. The WHO estimates that about every year, worldwide, there are about 30 million cases of measles infection. The children, they contract this disease on exposures, and the virus is introduced into the unexposed population every year. So the virus is present, it is sporadic, it is prevalent in the environment, and when you see the individual, they come into contact, particularly the children, they get this infection. The serious disease of measles has been reported into individuals who are malnourished, who are deficient in various vitamins, particularly the vitamin A deficiencies. And these people, they mostly belong to the developing countries who are not that rich in their resources. And the population of these countries has to compromise on their nutritional requirements and the vitamin requirement for their good health and immunity. The disease is very severe. It's a life-threatening disease, particularly in those individuals who are having cell-mediated deficient immune response, particularly the immunocompromised individual and the pregnant ladies. Pregnant females, immunocompromised individuals, they are more prone to the life-threatening complication or hazards of this measles virus. The pathogenicity is the infected cells lining of the upper respiratory tract. After entrance through the aerosol or the respiratory tract, the virus infects the cell linings of the upper respiratory tract, and from there it enters into the blood and infects the reticuloendothelial cells. This is the first stage. Now what happens? This is the first replication cycle. Entrance in the upper respiratory tract, enters in the blood, first viremia established, and then it infects the reticuloendothelial cells. Now then it replicates again, and then it's again spread via the blood to the skin. This is what we call the secondary viremia. So virus has the first viremia at the first stage and the second viremia at the second stage. In the first stage, it infects the reticuloendothelial cells. In the second stage, it infects the skin cells mostly. Now the rashes which appear on the skin, they are caused by the cytotoxic T cells that attack the virus-infected vascular endothelial cells in the skins. And once the rash appears, the virus is no longer recovered from these viruses, and it is not able to spread to the other individuals. So once the lesions they are formed, the virus become confined and cannot be spread to the other individuals. The multinucleated giant cells, they are formed as a result of the action of the fusion proteins, which is present in the spike. And this is the characteristic of the lesions. The lesions caused by measles virus, because of the presence of the fusion proteins, which is present on the spike and the envelope, they make the big cells, what we call like the multinucleated giant cells. This is the characteristic of the lesions which are caused by the measles virus. Now, the immunity that is conferred by this virus is a lifelong immunity. Once an individual has been exposed, there are maximum chances that the immunity will continue for the rest of its life. The IgG antibodies, they neutralizes the virus during the viremic stage. But in this case, the cell-mediated immune is more important. If the individual is not competent enough in its immunity, he or she may not have immunity for the rest of its life. The gamma globulinic children that was rich in the gamma globulin, they become subsequent immune and they are protected against this infection. They will not get the infection again. The maternal antibodies can cross the placenta barrier and they can infect the fetus or protect the infants. And the baby is almost protected for the 6 months of his life or her life for this disease. So all those viral diseases in which the antibodies, the maternal antibodies can cross the placental barrier and protect the fetus, this protection to the infant is for at least for the 6 months of the life. And that's why we have done the scheduled vaccination of measles, mumps, and rubella within that period of time. The transient depression of cell-mediated immune response against other intracellular microorganisms has also been observed with the infection of measles virus. Means that if an individual is infected with the measles virus, its immunity, the cell-mediated immune response may be transiently depressed, and the individual may be exposed to other microorganism infections like the mycobacterium tuberculosis. Now, if you have the mycobacterium tuberculosis infection, and the cell-mediated immune response has been depressed because of the infection of this measles virus, The purified protein derivative skin test, what you call as the tuberculin skin test, that may not give you the positive result because the cell-mediated immune response has been depressed by this virus. So you may get the false negative results. So you will have to keep this in mind. The reactivation of the dormant organism and the clinical disease can occur if the cell-mediated immune response has been depressed. The clinical findings of measles viruses depend upon the incubation period. After exposure, the incubation period for the appearance of the skin lesions, it varies from 10 to 14 days. In the initial prodromal stage, there is generalized symptoms like fever, conjunctivitis, photophobia, running nose, and cough. And then you see there is appearance of the complex spot, which are bright red lesions with white center dot on the mucosal membrane. And these complex spots are really important for the determination of the measles infections. They appear on the buccal cavity. Later on, there is the maculopapular rash that appears on the face, and then they proceed from the face to the gradually downwards in the bodies, the lower extremities, the palm, the soles, and then later on they become brownish in colors. So you can have the complex spots on the buccal area, particularly on the tongue, and you can have the maculopapular rashes on the face that can spread to the extremities, can involve the tongue and the palms and the soles, and if persist for some times, they can become brownish in color. Severe complications of the measles includes encephalitis and permanent sequelae such as the deafness and mental retardation. The deafness and mental retardation is because of the involvement of the spinal cord. And the both primary measles that appears in the form of giant cells pneumonia, what we call as the giant cell pneumonia, and the secondary bacterial pneumonia, along with the otitis media, which occur as a reference of the referred infection. They're quite common with this measles virus. Subacute sclerosing panencephalitis. It is another systemic infection or the disease of the central nervous system. This can also occur as a sequelae or as a complication or long-term effect of the measles virus. The pregnant women leads to an increased risk of stillbirth, not the congenital abnormality, because the rubella virus, they causes congenital abnormalities, whereas the pregnant woman in case of measles viruses, they are more prone to the risk of stillbirth. Now, the measles virus infections, it causes fetal death, which is more severe than the rubella viruses that causes congenital abnormalities, along with that of the cytomegaloviruses and many more viruses that cause the congenital abnormalities. The killed vaccine, it was used previously and it has been found to be associated with the infrequent atypical measles, which is characterized by the atypical rash with the complex spots. Now, this vaccine is no more in use. We are now the more refined form of the vaccines. So previously, you see, we can have the incidence of atypical measles in which you cannot see the complex spots, but the other signs and symptoms. The laboratory diagnosis of measles, of course, we can identify to some extent the presumptive diagnosis can be based on to the clinical grounds. The virus can be isolated on the cell culture, but it takes long times, needs specialized laboratory equipment, a specialized living culture to grow. And of course, you see the immune responses there. So the 4-4 riser antibody titer can also be used. And the PACRS is a highly sensitive and specific value, and this is really a good standard to rule out the possibility of other viral diseases. There is no antiviral therapy that we use in this case. Prevention is more important in the measles, rubella, and mumps disease. This is by the immunization, and the current immunization that we use is with the live attenuated vaccines. This live attenuated vaccine is highly effective. It's very safe, and it has very, very few side effects. So all newly born babies, the infants, they are vaccinated uh, against these measles, mumps, and rubella viruses. Uh, the subcutaneous, you see the injection to the children at 15 months is combination with that of rubella and measles virus is given. You can all learn all this about the preventive viral vaccination schedules and the bacterial schedules in your community medicine classes. So just to make you understand that the vaccines are available and we have this planned schedule for this purpose. Sometimes we do need the booster dose that is highly recommended, but not given to the compromised and pregnant women. This is a standard. The vaccine is always avoided in the immunocompromised and the pregnant women, and if we have to go for that, we have to be very, very careful. Unimmunized individuals, they must be protected by giving the immunoglobulins, which are the hyperimmunoglobulins, in which the antibodies has been provided in a lot of higher titer. And this is used for the unimmunized individuals. Now we move on to the next organism, that is the mumps viruses. And the disease it causes is the mumps, and it is characterized by the swelling or inflammation of the salivary glands. And this also occurs primarily in the childhood. The genome of the viruses gains the RNA genome, and you see the nucleocapsid is, the nucleocapsid is typical of paramyxo viruses. So you see the paramyxo viruses, the measles, mumps, they have almost the same structural composition. The variant has with two types of phenotypic spikes, one with the hemagglutinin and neuraminidase, and other with the cell fusion and hemolytic activity. This means that it has two spikes. The fusion protein spikes are different, whereas the hemagglutinin and neuraminidase spikes, they are different. There are single serotypes, as we see in case of measles viruses. Neutralizing bodies, they are again directed against the hemagglutinin antigen. So measles and mumps viruses, in which the neutralizing bodies, they are antibodies, they are directed against the antigenic hemagglutinin spike. There is single serotype, as we have in case of mumps, measles viruses. The internal nucleoprotein capsid, it has a soluble S antigen, and this soluble antigen is used in the complement fixation test for the detection of antigen. So the soluble antigen, which is a component of the nucleocapsid proteins of the viruses, this soluble antigen is used in the complement fixation test to detect the virus prevailing in the present in the blood. The replicative cycle is similar to that of the measles virus that we have already discussed. The respiratory droplets are the source of infection. They spread the infection, the worldwide distribution, peak incidence we record in winter seasons. There is no epidemic, the outbreaks like we have in case of measles. The mumps infection mostly occur in winter season. Almost 30% of the children, they have immunity due to the subclinical or inapparent infection. But the virus has been spread, has been there in the environment every season in the winter season. So the population is continuously exposed to the presence of the virus. Because of this, the almost 30% of the children, they are already exposed. They have inapparent infections. So they almost have the immunity that can protect them for the further severe complication or the onset of this disease. The widespread use of the vaccine in the childhood, it has greatly reduced the incidence of the viruses. So most of the viral infections, they have been tackled by prophylactic, as the vaccines, they are available, and we have a well-established protocols and standardized timing for the injection or for the immunization purpose. The pathogenicity of the mumps, you see again, it infects the upper respiratory virus, infect the respiratory tract, and spread by the blood and infect the salivary glands, which causes especially the pituitary glands, the testes, ovaries, pancreas, and meninges, can cause hepatitis, the orchitis, and pancreatitis, meningitis. in sending infections from the buccal mucosa up to the Stensen's duct that goes to the parotid gland can also occur. Disease, it confers lifelong immunity once an individual has been exposed once in her life. The subsequent cases of parotitis, it can be caused by parainfluenza virus or some of other bacteria or some of the duct stones. But you see the underlying cause is always the mumps viral infections. The maternal antibodies, as we have seen in case of the measles, they can cross the placenta, can provide protection to the fetus or baby or the infant for at least 6 months of period. And during that period, we use the measles, mumps, and rubella virus to provide protection to the baby. Incubation period is about 3 to 4 weeks time. And in the early stage, there are again the same signs and symptoms, and we can hardly differentiate between the various viral issues like measles and mumps and influenza and parainfluenza. The fever is there, the malaise and anorexia, that may be followed by the tender swelling, salivary gland. This is important in case of mumps. Either this swelling may be unilateral or it may be bilateral. So there is the increase in the parotid gland, pain, and the pain is of that extent that you cannot even drink, and if you drink some citrus juice, it will give you more, there will be exacerbation of the pain. Now, typically begin disease as resolved spontaneously within 1 week time. Two significant complications that can occur as disease of mumps are the architis in post-pubertal males, and if bilateral, this architis can result into sterility, lifelong sterility, because the pressure necrosis of the spermatocard in the post-pubertal, it is due to the involvement of the fibrous tunica albuginea. There is a pressure and there is a necrosis, and this results into the resistant expansion, unilateral architis. There is a pain and sterility. The meningitis, which is of benign in nature, it's a self-limiting disease, and there is no sequelae, as we can see. Now, there are many more viruses and bacteria, particularly the viruses like the mumps viruses, the Coxsackie virus, the ecovirus. These are the three more important viruses that causes meningitis. And the viral meningitis is known as aseptic meningitis. The bacterial meningitis is a septic meningitis. Now, if you take this CSF, if you withdraw the CFS, the bacterial meningitis would cause yellow color. It will change the color of the CSF. Whereas in case of viral meningitis, the color of the CSF will remain the same. This is one sign. We do have many more that you will learn in the chemical pathology. But just to keep in mind that the viral meningitis, you will not see any color change in the CSF, but this color change would be of yellow to light green in color in case of bacterial meningitis. The lab diagnosis of mumps, again, based on the clinical finds, we have the confirmatory test that can be used in the laboratory. We can go for the isolation of the virus in the cell culture. We can isolate the virus from the saliva, from spinal cord, from urine, PCSR assays, and other important tests. 4-fold rise in antibody titer can be of use. We can have the hemagglutination test or the complementation test. These are again the diagnostic test. We can have, you see, the two different antibodies. The S antigens, which antibody to the S antigens, it indicates the current infection, whereas the V antibodies, this indicate the prior infections. The skin test is based on the delayed hypersensitivity infection, and it indicates the previous infection. Prevention is again with immunizations. We have the live attenuated vaccine. This vaccine is again safe, effective, long-lasting, and one shot of vaccine provides protection for about 10 years' time. The two immunizations are most important, provided or recommended, one at 15 months and the booster of 4 to 6 years of time. This vaccine is, because it's a live attenuated vaccine, so as a rule, Any live attenuated viral vaccine should not be given to the immunocompromised individual and to the pregnant woman. They may be we can provide protection to them with the hyperimmune serum, but we cannot give the shot of attenuated live vaccines. The immunoglobulins, they are not useful in preventing our antigenic orchitis. Once you see the sign is there, the immunoglobulin, it's not going to work. Sporadic outbreaks in adults have been reported both in the immunized and immunized persons with a different genotype. Now, the next one is the respiratory syncytial virus. This virus causes diseases known as pneumonia and bronchiolitis in infants. It causes otitis media in children and pneumonia in elderly and in patients who are having chronic cardiopulmonary diseases. So one virus, three different, the same diseases, but with different clinical symptoms and involvement of the organ. In infants, it causes pneumonia and bronchiolitis. In children, it mostly causes otitis media along with that of pneumonia, but it causes pneumonia in elderly, immunocompromised individuals and those who are suffering from chronic pulmonary diseases. The genome of respiratory syncytial virus is again the RNA genome, nuclear capsid symmetry, as we see in case of other paramyxo viruses. The surface spikes, the fusion proteins, they are there. There is no HA or NA, no hemagglutinin or neuraminidase. And fusion proteins, they cause cells to fuse and they form multinuclear giant cells. And this multiple nuclear giant cells is known as syncytia. This syncytia is the name that is given to the designate the respiratory syncytial viruses because of the larger size of the virus, the cell that we can see because of the fusion of the cells, because of the fusion proteins. The humans, as another case, the measles and mumps, they are the natural host. We have two serotypes, serotype sub A and B, and these serotypes, they are detected by the monoclonal antibodies. Monoclonal antibodies are the highly specialized antibodies that has been raised against the highly specific antigens. So the monoclonal antibodies is again an other important parameter to identify the highly specific antigen. So the antibody against the fusion proteins, they neutralize the infectivity, and the replicative cycle is again the same as we have seen in case of measles and mumps viruses. Measles, mumps, and rubella, they all have the same replicative cycles. In pain, again, you see the disease is through the respiratory droplets or by direct contact of the contaminated hands with nose and mouth, as you see in case of coronaviruses and influenza viruses or the parainfluenza viruses. The outbreaks of respiratory infections in every winter and diseases worldwide, virtually everyone is infected within 3 years' time. Outbreaks of respiratory infection, particularly in hospitalized infants, it has been reported with the respiratory syncytial virus. This is controlled by the washing and using of the gloves and face by the nurses. So if the paramedics, they are using the PPEs properly, and the hand washing procedures, they're strictly followed, there are least chances that this outbreak will occur. So the only way to control hospitalized infection, whether of bacterial origin, viral origin, is to wear the mask, hand washing, and wear gloves, and properly follow the SOPs of infection control. The pathogenesis is, this virus is more severe in infants and involves the lower respiratory tract. The infection is localized to the respiratory tract. Viremia does not occur in this case. Disease is very severe in infants and in immunopathogenic mechanism, immunocompromised individuals. The maternal antibodies, they react with the virus and they form virus antibody complex, what we call as the immune complex. And these immune complex, they damage the respiratory tract cells, and the killed vaccine trial results in more severe disease. So we should not go for the killed vaccine trial. the disease is mostly immunogenic, or the results are the immunopathogenic mechanism is involved over there. There is incomplete immunity. Multiple infections of respiratory virus can occur, not due to the antigenic variation of the virus. The IgA respiratory antibody reduces the frequency of infection. Now, the multiple infection of a respiratory tract, the respiratory syncytial virus is not because of the antigenic variation. It's not due to the antigen. Antigen is almost the same. So this means that there may be some other mechanism involved in that. Clinically, you see the lower respiratory tract disease like bronchitis, pneumonia, otitis media in young children, respiratory tract infections, common cold, bronchitis, severe lower respiratory tract infection in the elderly, particularly over 65 years of age, adults, and with chronic cardiopulmonary diseases or with the immunosuppression. Now, if you look at the replication cycle, it is almost the same. If you look at the route of transmission, almost the same. If you look at the clinical findings, they're almost the same. If you look at the different anatomical structures of the component of the virus, they're almost the same. So that's why you see it is a group of viruses, but it has been given a specific species name because of some slight variations in the makeup of the viruses. So replicated cycle is the same. Clinical findings are almost the same. Transmission are almost the same. So it's very easy to remember all this group of viruses. The lab diagnosis, again, you see detection of antigen in the respiratory system by ELISA, immunofluorescent assay, a smear of the respiratory epithelium, isolation cell cultures, and we can see the cytopathic effect by formation of multinucleate giant cells on the tissues. Again, we can go for the four-fold antibody titers, and we have the RT-PCR. PCR is again sensitive and highly specific. That was all about the respiratory syncytial viruses. We are left with the treatment. It is nothing more. Aerosolized ribavirin, it is recommended, particularly for these severely ill individuals, hospitalized infants, and but we are still uncertain with the effectiveness of this combination of this disease, of this medicine. So the combination of ribavirin with the hyperimmunoglobulin, that may have given the good results. So if you have some hospitalized baby infected, you are facing some of the other individuals who may be getting an infection from that baby within the nursery ward, you can try the combination of ribavirin along with that of hyperimmunoglobulin. There is no vaccine. There is a killed vaccine available, but that has been resulted into severe signs and symptoms. So there is prophylactic with monoclonal antibodies. They can be used, that antibodies has been directed or has been raised against the furin proteins, and they are available with the name of Synages in the market, and we can use that, and it can be used in the premature or immunocompromised infants. So vaccine is not available. We have the monoclonal antibodies available, and that can be used, that are really effective. Hyperimmunoglobulins, which are available in the market within the name of Respigam. In chronic lung diseases in individuals, it can be used. Nosocomial outbreaks can be avoided by hand washing, by gloves, by following proper and standardized SOPs in the ward. That is all about the measles, mumps, and respiratory syncytial viruses. We're still left with one or two organism viruses in this group that we'll take next time. Thank you very much.